serious debate, obviously.
Pronounce Ofer. Yeah. Order, order. Sign over to move the motion.
Thank you, Sir John, and it's a pleasure to serve under you. And I'm grateful also to the Backbench Business Committee for giving me this opportunity to open this debate on the role of the NHS in preventing and dealing with domestic abuse when it presents to the NHS. Can I also thank the member for Lowestoft, who, since we secured this debate, has been appointed as the Violence Against Women and Girls Advisor for the Department of Health and Social Security. So I think we shall hear from her later. I also want to place on record my thanks to Standing Together Against Domestic Abuse, IRIS-I and Respect, and also from my own constituency, the Stroud Women's Refuge, who have really helped me with this speech. I'd also like to declare an interest. I am a working GP and sometimes need to deal with these issues as well. So, on average, 5 people a week die as a result of domestic abuse in this country. And actually now there's more suicides related to domestic abuse than actual homicides. And behind each of these statistics, these 5 people a week, this is a life lost and also a family devastated. And in far too many cases, Chair, there has been repeated contact with health services, and there has been moments when the health service could have intervened. So the NHS is actually the most consistent point of contact for people living with abuse, and about 500,000 people seek support from the NHS each year in relation to domestic abuse. And 85% of them ask at least 5 times before they receive effective support. This isn't because clinicians don't care. This is really about recognition of domestic abuse and about getting referral services that are easy to understand and well known in practice. So if we are serious about preventing domestic abuse, then we must be serious about the role of the NHS, not just in primary care, but across all mental health services, across maternity, and through emergency departments and through community care. So it has to go right across the NHS, not just in primary care. So this really is a debate about making sure we don't miss chances and that we have meaningful intervention when people present with signs of domestic abuse. The violence against women and girls, this government has committed to delivering on our promise to halve violence against women and girls by 2029, and I really welcome the comprehensive strategy to tackle this. For too long, support services have been unable to support victims and survivors effectively without sufficient resources, and in too many cases, women and girls have not been able to access the support they need. So I really welcome this government supporting victims with the largest ever investment of £550 million in victim support over the next 3 years, and an additional £5 million each year from the Department of Health and Social Care. So I would like to just say a few things about how GPs specifically are often the first port of call, and how presentation to GPs is incredibly important that we recognise. So I'd like to just quote from Killed Women, an organisation for bereaved families of women who were killed by men in the UK. She had gone to the GP a few days before her death as she couldn't take any more. She was only offered antidepressants. On the day of her murder, when I spoke to her, she said they weren't helping and she had not had enough. She said that the GP knew her situation, but yet again, she failed there. So this shows that simply giving out antidepressants isn't the right strategy, and we need to build support around women who are subjected to domestic abuse. They often present with mental health issues, and they often will not say any details of their abuse. So one of the things that I teach other GPs in training is that there's something called a hidden agenda. Women particularly will present to the GP, but they won't say that they're being abused. They will have other symptoms, and we must recognise that presentation straight away. There are ways that we can recognise that. Sometimes the the woman in question will present with a partner, and she won't feel comfortable to talk about the situation. Now, what I often do is ask the partner to leave the consultation, speak to the women individually, and this can be a really effective way of finding out exactly what's happening. We also need to be aware that often women in this situation are nervous and they're walking on eggshells. We also have to recognise that often there are physical injuries, often of different ages as well, and we sometimes see women presenting in sunglasses to cover up a black eye, for example. So all these are symptoms that we must recognise as a health profession. That we also need to recognise, as I've said before, that there are very high rates of mental health problems, and often women who are being abused present with symptoms of depression which actually are underlined by this domestic abuse. So we need to start to inquire in women who are depressed whether there's anything going on at home. Female survivors of domestic abuse are 3 times more likely to develop mental illness. There's also other high-risk periods, like when women are pregnant, and they often have poor outcomes in this situation. And we also must be aware right across the health service that women may disclose domestic abuse. So, for example, health visitors are in an ideal situation to hear this type of thing and must be aware of this potentiality. In A&E, it's also very common that women present, and often women present with overdose, and underneath that there's domestic abuse. Midwives often presented with this, and obviously mental health workers, even gynecology services. This is often behind that type of thing, and social services as well. So often women will present to health service with different symptoms, but this really is a cry for help, and we must recognise that. So what do we need to do to really support these women? Now, one of the things I'm really delighted about is this concept of steps to safety. The Department of Health and Social Care will roll out a domestic abuse and sexual violence referral service across integrated care boards, and it will give GPs the tools and ability to identify and refer victims and survivors into support. Now, what's really important about this, it's a simple service with one number, because if it's not simple, then it won't be used by health services, and that's incredibly important. And it's also important that we make use of existing resources. I visited the Sexual Abuse Resource Centre at Gloucester Royal Hospital recently. It's a fantastic resource with really well-trained staff, and they're available 24/7 as well. Can I also say that it's really important, particularly in practices, to have a safeguarding or domestic abuse lead, and they need to be totally up to date with what is available, because quite often services change and GPs themselves aren't on top of that. So that's really important as well. Can I also stress the importance of women's refuges? So in Stroud, we have a fantastic refuge. They don't advertise themselves for obvious reasons, and the people working there are simply amazing, supporting women who have difficulties, and often their children as well. And it's really inspiring to see the work they do. And it's really important that these services are available immediately if the women feel in danger. So can I also just make a plea for support, actually, for the perpetrators of abuse? Now, usually men that perpetrate abuse often abuse at least 5 times. So it's actually really important to catch them on the first time and actually institute really good treatment and management for them. There's often drugs, alcohol or mental health behind their problems, and we must deal with them before they continue to abuse. So although that's controversial, I think that's incredibly important as well. So what do we need for the whole of our health strategy? We need things to be coordinated, and I noticed that there's a suggestion that we have a domestic abuse coordinators for a group of GP practices. And as I said, I think we need to have leads in general practice, one person who is leading in that, so they can keep up to date and keep reminding the other members of staff that that's really important. Can I also say, when we're training in primary care, it's really important that we train everyone. So, for example, the receptionists in primary care often are aware of the people coming in, and they need training to detect domestic abuse so they can inform the doctors. So it's a whole team approach. Pharmacists as well, and also nurses and physiotherapists need to be trained and aware of what are the signs and symptoms of domestic abuse. Can I also say that this training should be essential for everyone, but can I just take a step back against mandatory training? Many people in the health service find this irksome and a tick box exercise, and what I don't want is for domestic abuse training to be simply a tick box. You go on an hour's course every year, and that's it. We need a more integrated approach, and it needs to be part of an appraisal process, so every doctor and nurse and healthcare worker is aware and trained in domestic abuse without having a mandatory put on it, so that it doesn't become simply a course that people have to go on, but actually they get properly integrated into the surface. And then, last of all, and this seems incredible in this day and age, but we need to share data between all the health services. For example, A&E, GPs and mental health. Mental health, we often don't get any information from mental health, and it's really important that we get that data sharing really up to speed, because, as I say, domestic abuse can present in many different situations in the NHS, and it's important that everyone is aware of the risks. So, in terms of funding, whilst there's £5 million a year from the Department of Health and Social Care, it's a good first step, but I do feel we need quite a lot more than that to really bring this whole service to the fore. So I'd like to conclude now, if I may. So if we're really serious about preventing domestic abuse and the death that so often follow it, then the NHS must be properly equipped to play its full role. And there are 3 points I'd like to make. It's firstly about this funding, and this is around training and about investing in services that will really help in domestic abuse. And as I say, these steps to safety are key, because it must be simple for women to access this service. And it's also really important that wherever a woman presents to the NHS, that person is trained to detect that domestic abuse and is aware of what's available for that woman. And finally, we must have a comprehensive whole health plan for the NHS and for tackling domestic abuse and violence against women and girls. And this must cover primary care, mental health, maternity, accident and emergency service. And I'd like it to be published by 2027 at the latest. So, yes, certainly, yes.
And thank you, Sir John, and your chairmanship. It's a pleasure to serve. I'd like to thank Member Stroud for bringing this debate. I want to highlight, you mentioned right at the beginning around suicide, and obviously when you're talking about NHS services, when we've got women trying to take their own lives. I wanted to highlight a devastating impact of 2 members from Portsmouth who took their own lives because of coercive control. So would the Honourable Member agree with me that all of the agencies across the NHS, across our health service, is a public health issue, as well as our police service, need to be joined up to stop the loss of lives?
Can I thank my honourable friend from the member for Portsmouth North, and I know that she is really invested in trying to help women from domestic abuse. I do think this coercive control is very important, and that often stops women presenting to healthcare workers. And as I've said before, one of the key things is, as a clinician, you have to be brave and ask the man to step out so you can have a proper... And often they resist this and can get violent as well. So this is something that it's really important that we take a brave view to protect women in general. So I'd like to just conclude then, is that if we get those 3 things right, around the funding and about recognition and about a comprehensive and integrated care service, that we can move forward to a service that repeatedly sees and recognises abuse and immediately steps in to stop it. So that's the shift that this debate is calling for, and it's one that could save many lives. Thank you, Mr. Chair.
Thank you, Simon. I remind members, although I can see they already know, that they need to bob it to catch my eye. The question is that this House has considered the role of the NHS in preventing domestic homicides and domestic abuse-related deaths. Sarah Oldney.
Thank you very much, Sir John. It's a pleasure to serve under your chairmanship. And can I congratulate the Honourable Member for Stroud for securing this important debate. He's a real champion for the NHS, and it's a benefit to all of us that he brings his former experience as a GP to bear in this debate. The NHS has more contact with people experiencing domestic abuse than any other service, and therefore it is vitally important that staff in the NHS feel adequately equipped to comfort and reassure victims who take that brave step of reaching out for support, often for the first time. In turn, it's essential that victims can feel confident that when they confide in the NHS, the staff members that they speak to have the knowledge to properly support them. So while NHS staff do receive the statutory general safeguarding training, it can be easy, as the member for Stroud has already detailed, to miss the signs of abuse and the cries for help, and especially when staff are tired from working extensive and difficult hours. As a country, we have so much to thank our NHS for, whether it be from the sacrifices that staff made during the pandemic to working additional hours to take care of our loved ones. So my speech is really intended to ensure that the staff have the tools that they need at their disposal to help the most vulnerable, rather than critique their best intentions. And victims are so often hesitant to ask for support. They feel trapped by their abuser. They fear the repercussions. And the extent to which domestic abuse and sexual assault is known to the authorities is somewhat unknown. It's estimated only 16% of people report their experiences to the police. And one reason for this is a mistrust in the authorities, which emphasises the importance of ensuring that those who treat victims' injuries are prepared to provide them with the help and support that they need. Of the 16% of people who do report an assault, only 2.6% of alleged offenders are charged or receive a summons. So even in cases in which the offence takes place in public, the percentage of reported sexual assault offences which receive charges is disproportionately low, fewer than 5% of reports on public transport resulting in a charge in 2025. Now, while death is tragically the end result of too many domestic abuse cases, there will have been a point in almost every single case in which a step could have been taken to better support the victim. A report commissioned by Standing Together Against Domestic Abuse underscored this fact. As of the 47 reviews of deaths related to domestic abuse published in 2024, 89% contained reports of an instance in which our health service had the opportunity to step in and do more to help. While domestic abuse training is mandatory in the social care system, the same training is not always made available to other frontline services in the NHS. This is clearly something which could be rectified, and so I'd be really interested to hear what the Minister has to say about how the government might take steps to ensure that domestic abuse training is stepped up for our NHS frontline services. Will they release the funds to ensure that every NHS frontline member of staff has access to mandatory domestic abuse training? Thank you, Sir John.
Thank you. Chester Santo.
Thank you, Sir John. It is a pleasure to serve under your chairmanship, and I'd also like to thank the Honourable Member for Stroud for securing this debate on such an important issue. 44% of victims surveyed by the Domestic Abuse Commissioner in 2022 said that their first disclosure was to a healthcare professional. Unlike the criminal justice system, health spaces focus on well-being and recovery, and are therefore a crucial front door for identification and referrals into specialist services. Not just for the many women affected by domestic abuse, but for the 105,000 children who right now live in homes where there is high-risk domestic abuse too. And we know that those victims who reach out to police are just the tip of the iceberg, given that fewer than 1 in 5 victims ever contact the police about their abuse. So getting our response to violence against women and girls right in healthcare is the key to unlocking our ability to properly tackle domestic abuse. And it is for that reason that I was delighted to be asked by the Health Secretary to become his Violence Against Women and Girls advisor. I worked for 6 years at the domestic abuse charity Safe Lives and saw firsthand the huge role health could play. In the report, Cry for Health, we found that nearly a quarter of victims at high risk of serious harm or murder had been to A&E as a result of domestic abuse injuries in the year before they were able to get help. But we also found that staff were worried about asking, even though this is required under NICE guidelines, because they felt they would open a can of worms and in some cases might make the situation worse. We found victims visited
A&E in some cases 15 times before getting the help they needed. Health professionals were patching victims up and sending them back into the violent and controlling arms of their abusers. Research from Standing Together Against Domestic Abuse, as we've heard already, has shown that in 2024, 89% of domestic homicide reviews had at least one recommendation for the health system or professionals that could have helped to save the life of the woman who had been murdered. I have met with families whose relatives have been killed after repeated contact with health services. In Safe Lives report on health in London, a survivor who was interviewed, who did disclose at A&E, said, "The doctor told me, we only do bones here, not that relationship, mental health stuff. But he didn't offer to refer me to somewhere that did." This has to change. In 2018, Elena was killed by her partner Razvan. The month before her murder, she was treated in hospital for abdominal pain after using crack cocaine. But she left hospital with Razvan before she could be discharged. As a result, a child family assessment was conducted, and they were visited at home together the day before she was killed. She wasn't seen alone. She was never seen alone. She was pregnant. Razvan was with her and never, ever left her side, and no one sought to question her on her own or spotted that she was the subject to an extensive range of domestic abuse as well as sexual exploitation. There are, of course, thousands of hard-working health professionals who do safeguard their patients, but it is clear there is so much more to do. I will always remember a senior GP who told me, honestly, after asking why health didn't share information when a patient was at clear risk of serious harm. He said, "Well, I care more about the thud of an envelope with a GMC logo on it than hearing that one of my patients has been murdered." That is why the co-location of specialist domestic abuse professionals in all health settings is so important. The Cry for Health research found that IDVAs, independent domestic violence advisors, when they're located in hospital settings, have a net positive saving of £2,000 per victim in health costs, and also lead to 84% of victims feeling safer, with 73% seeing an improvement in their quality of life. It is about their health, it is about their well-being. That makes them both safer and more likely to recover. Hospital-based IDVAs also identify victims earlier on average. It is a preventative measure, with their clients on average experiencing 6 fewer months of abuse than those victims engaging with local services. We can prevent abuse by the co-location of specialists in health settings. And of course we know that co-location works in primary care settings too, as the IRSI programme has demonstrated for decades. That is why Steps to Safety, announced in the VORG strategy just before Christmas, as we've heard, is so welcome. The programme aims to ensure that by 2029, any victim or survivor in England can get the help they need through their GP. It will also ensure that each GP practice is linked to specialist support workers who can support victims to access their local specialist support services. And it is crucial that the support is independent from statutory services and sits within those local specialist services, not generic services, if it is going to be trusted by victims. As well as supporting the department to roll out Steps to Safety and looking at other areas and neighbourhoods to locate VORG expertise, I will also be focused on improving VORG commissioning in the NHS and exploring links between alcohol and violence against women and girls. I am clear, as is everyone, alcohol does not cause VORG, but it can be a factor in escalation and serious harm. There is much I have not shared: mental health, maternity, links into family hubs and other community health settings when we need to be exploring the role of health. But we need to treat this as a public health epidemic if we are going to reach our goal of halving VORG. If anything, health has a bigger role to play than the police and courts in identifying and providing life-saving support for adult and child victims, and for perpetrators too. I'm clear that the DHSE is serious about doing just this, and I'm personally committed to do everything I can in my role to help.
Thank you. Jim Shannon.
Thank you, Sir John. As always, a pleasure to serve under your chairship. But also, can I thank the honourable gentleman for Stroud for securing the debate and for setting the scene so incredibly well and giving us all an opportunity by his debate to come along and participate. As always, Sir John, I want to give a Northern Ireland perspective of what's happening. And unfortunately, things that are happening in Northern Ireland are replicated by what the other speakers have said, and others will speak afterwards. And in some ways, of course, things in Northern Ireland are even worse. And the level of killings of women in particular are such a heavy or high level that in proportion to the rest of the United Kingdom, they outpace what's happening. The Honourable Minister, who is here, and I always pleased to see the Minister in her place, has a special interest in Northern Ireland. I know she has. Because of that, the Honourable Lady will be aware of the stats, which are incredibly worrying. In Northern Ireland, the Police Service recorded some almost 30,000 domestic abuse incidents in the 24-25 period, translating to roughly 85 incidents daily, with some almost 18,500 of those becoming crimes. Although many incidents do go unreported, and call volumes, particularly around Christmas, highlight a consistent challenge for victims seeking help. It's almost about 15 incidents and 10 crimes per 1,000 people, puts the stats into perspective. And whilst this is a decrease from the year previous, those numbers are still incredibly jarring. Of course, one of the worst times of the year, as we all know, as I like to represent, is Christmas and New Year, Sir John, where there's a strain in relationships, whether it's a combination of financial pressures or emotional pressures, or everything builds up at that time of the year, or whatever. The PSNI, in the period ending January 2nd, 2026, the PSNI received some 1,407 calls, with the New Year's Day, January the 1st, seeing a peak of 116 reports. Again, pressure on the PSNI back home, or in the police here, to respond to quite difficult issues. So again, my question to the Minister, always trying to be helpful, and I know the Minister always tries to be responsive to our requests, has the Minister had the opportunity to speak to the relevant police in Northern Ireland to get an idea of what they're doing, and perhaps maybe how we can help each other? We had the absolutely, give an example, we had the absolutely heartbreaking murder of a young mother of 2, pregnant with her 3rd child in June, and the ripples are still felt within our community. Young Sarah Montgomery's murder simply should not have happened, and more has to be done in these cases. Sarah was the 27th woman to be murdered in Northern Ireland since 2020, and the level of domestic abuse calls indicate that this remains a central core problem. In Northern Ireland, the NHS, the Health and Social Care, is a central partner, a very important partner, in the Domestic and Sexual Abuse Strategy 2024-2031, which designates domestic abuse as everyone's business, and it is everyone's business. Health settings are often the only safe, trusted environment where a victim can disclose abuse. And the Honourable Gentleman referred to that in his introduction, because when you get there, you have people around you to support you. There's nobody looking over your shoulder or listening to what's going on, and you may have an opportunity to disclose what's happening. So really important to have that strategy in place, and we have that in Northern Ireland. Can I underline those particularly worrying trends over the Christmas and New Year period as an example? At that time of the year, accident and emergencies are under incredible pressure. With back home we've had the problems with hospital waits, ambulances queued outside. Again, the domestic abuse issue is very clearly in the middle of it. Because some roughly 30% of domestic abuse starts during pregnancy, midwives and health visitors are trained to conduct routine inquiry, asking about safety at home, and they do that. And I think what they do has enabled the issue to be raised incredibly. To catch abuse early, we need to empower these workers to report any concerns and to ensure that there is support offered. It is essential that the NHS departments work together, but with the pressure on workers to fulfil their calls and also their paperwork, the pressures are immense. So I believe that we must have time factored in for staff to be able to smoothly report any suspicions and to know that in these awful cases, the government and the departments have done all that they could. I conclude with this, Sir John. I want to be clear. Murder by domestic abuse can never be the fault of anyone other than the perpetrator. However, we must all ask ourselves within a community, was there something more that we could have done? And I support a review by the Minister that is UK-wide to ascertain what we can do to know that we have done all we can to our utmost and even a bit more. Thanks very much.
Thank you. Cat Eccles.
Thank you, Sir John. It's a pleasure to serve under your chairship, and I'd like to congratulate my honourable friend for Stroud for securing this important debate today. Domestic abuse is too often framed solely as a criminal justice issue, when in reality it is one of the most urgent public health crises we face, and the NHS encounters victims and perpetrators far more frequently than any other service. Yet the system consistently misses opportunities to save lives. As the BMJ has highlighted, less than 24% of domestic abuse crimes are reported to the police, meaning it is the health service and not law enforcement that is the front line. A recent review of domestic abuse-related deaths revealed that 89% of domestic homicide reviews contained at least one recommendation for the NHS, recommendations that occur again and again across cases. They show a pattern of missed signs, inconsistent responses, and staff who suspect something is wrong but lack the training, systems, or perhaps the confidence to act on that. Now, NHS staff are uniquely placed to intervene in suspected domestic abuse, and in my own career as an operating department practitioner working in theatres, I can recall many instances where we treated patients with what seemed like run-of-the-mill injuries, but all was not as it seemed. Like the young woman who came in for manipulation under anaesthesia of nose after breaking her nose in a fall. But she became inconsolable when we told her that she could not go home, that she could go home after the operation. "Can I not stay overnight?" she cried. And as I talked to her more, we discovered she was being abused at home by her partner. But I also want to highlight honour-based abuse, which I sadly encountered many times in my career, from extreme female genital mutilation to the woman undergoing an endoscopy for a severe esophageal pain, which turned out was from her family poisoning her with battery acid, stripping the lining of her esophagus and stomach. These suspicions are not always explored, despite clinical teams being highly skilled, compassionate professionals, and the opportunity to intervene can really easily be lost. Mandatory standardised domestic abuse training is essential, and experts estimate that delivering consistent training across the NHS would cost just £2.6 million per year, a really tiny fraction of the entire NHS budget, but with the big potential to save lives. We also know that poor coordination between agencies is repeatedly cited in death reviews, with 35% calling for multi-agency working. And the Domestic Abuse Commissioner has stressed that domestic abuse deaths require accountability across entire systems, particularly the NHS, which must implement lessons from domestic abuse-related death reviews and participate fully in the new National Oversight Mechanism. But preventing domestic abuse deaths also means understanding the complexities of coercive control. Something like Survivors and Domestic Abuse campaigner from my constituency, Samantha Billingham, have worked tirelessly to highlight. Coercive control is often invisible, yet is one of the clearest predictors of escalation to serious harm and homicide. And if professionals do not understand coercive control, they cannot identify the danger. That is why social workers must receive mandatory specialist training in coercive control. They are often the first professionals to see patterns emerging across family, mental health, housing and safeguarding contexts, but too often their training does not equip them to recognise or challenge the dynamics of manipulation, isolation, surveillance or financial control that underpin domestic homicide. The NHS must also embed specialist domestic abuse support directly into clinical settings. The government's upcoming measures, including the Steps to Safety initiative, aim to ensure every part of England has dedicated NHS referral services for victims, with specialist support workers linked to GP practices. And these reforms are welcome, but they must be implemented at pace and fully resourced if they are to prevent future deaths. Domestic abuse deaths are preventable, and they are preventable when we train our workforce properly, when agencies work together, and when we treat domestic abuse as a health issue, not just a crime issue, and when we equip professionals to understand the controlling patterns that escalate into lethal danger. It is all of our responsibility and the NHS's to ensure no victim is left unseen, unsupported or unheard.
Thank you. Kerry Whistle.
Thank you, Sir John, and it is a pleasure to serve under your chairship, and I thank my honourable friend, the member for Stroud, for securing this important debate, crucially focusing on the fact that this has to work across the NHS, and I think that's a really important point. When domestic abuse is escalating towards serious harm or death, what can the NHS do to stop it? Because for too long we've talked about domestic abuse as if it happens outside public services, as if it starts and ends behind closed doors. But the truth is this, the NHS is already in the story, it just has to connect the dots. The moment you sit in a GP waiting room trying to keep your voice steady, the moment you turn up at A&E with an injury you can't easily explain, the moment you're pregnant at a maternity appointment and you're terrified of going home, or you want to ask for help but you can't because your perpetrator is sat there with you. Those are moments of contact with the NHS and crucial opportunities to save a life. So my first point is about duty of care. The NHS absolutely has a duty of care to its patients, not just to treat injuries, but to respond when someone is at risk. And in domestic abuse, risk isn't theoretical. In the most recent national figures, we saw 108 domestic homicides a year. And for the first time, suspected suicides linked to domestic abuse have overtaken intimate partner homicides. That is a flashing warning light for the health service. If suicide is preventable, domestic abuse-related suicide must be treated as preventable too. But a duty of care is only real if staff are trained and equipped to carry it out. Because if someone reaches out in the NHS and gets silence back, or disbelief, or a note taken with no action, that can be the moment they stop asking for help. In domestic abuse, missed moments can be fatal. Which brings me to my second point. For the majority of victims and survivors, health professionals are the first place they disclose, and sometimes the only place. People often assume a victim's first call is to the police, but for many survivors who disclose, their first brave step is often telling a GP, a midwife, a nurse, a health visitor, or even their pharmacist. Our healthcare system is the front line of support for victims of domestic abuse. And tragically, too many survivors are forced to seek help again and again before the system even responds. In fact, 85% seek professional support around 5 times before they finally receive help. In Bolton, we can see both the challenge and one of the solutions. We operate a system called IRIS, Identification and Referral to Improve Safety, a specialist training programme that links GP practices directly with domestic abuse support services. IRIS is delivered in Bolton by Fort Alice, the local domestic abuse charity, and I'm incredibly grateful to Jill and her team for their hard work. Since IRIS began back in 2014, nearly 3,000 victims have accessed support, and 274 healthcare professionals were trained in the last year alone. That training matters because it changes what happens in the room. It helps clinicians ask safe questions, spot warning signs, and act, so that when someone says, or their face or demeanour tells us that I'm not safe, the response isn't panic or paperwork, it's support. And we need that consistently because Bolton has seen what happens when the system doesn't join the dots. One case that has stayed with local services is the domestic homicide review of Margaret, not her real name, an 80-year-old woman killed by her husband in 2019. While the husband was in hospital, Margaret disclosed fear and abuse and said she didn't feel safe. Those concerns were discussed in a meeting between hospital staff and social workers, yet once his physical health stabilised, Margaret's husband was discharged home, and days later, Margaret was dead. So, John, if a patient can say, I am not safe, and the NHS can't act, and the NHS is not yet safe enough. So how do we make it consistently safe? I have 3 practical asks. First, proper and consistent domestic abuse training, not a one-off e-learning module, but trauma-informed training, refreshed over time for the whole team, including, as my honourable friend mentioned, reception staff, who are often the ones who see those warning signs first. The government has said it will launch a mandatory safeguarding learning programme that covers domestic abuse. That is welcome, but it must be embedded in day-to-day NHS practices. Second, sustained funding for evidence-based pathways like IRIS and the specialist services that they rely on, because referral routes only work if support exists and exists safely. The government has set an ambition that by 2029 there will be dedicated referral services for women and girls affected by abuse in every area of England. That is exactly the direction we should be travelling in, but those routes must cover the whole of the NHS. And finally, the NHS should establish a universal code word scheme so that a victim can ask for support just as easily as we can at pharmacies, a bar, a pub, or even a restaurant. The NHS is our front line and absolutely needs to be well equipped to spot, safeguard against and deal with domestic abuse, as it should have been doing for decades. Sir John, domestic abuse thrives in silence and isolation. The NHS can be the opposite of that, a place where someone is seen, believed and connected to safety. Bolton has shown what's possible when services work together, when we connect those dots. Now we need our NHS to match that with consistency, because every week we delay, more families will be left asking the most painful question of all. They reached out for help, so why were they still not safe?
Alex Sobel.
Thank you, Sir John. I'd like to start by thanking my honourable friend, the member for Stroud, not just for this debate, but for all the work that he does in the NHS as a GP on the issue of domestic violence and abuse. The NHS has opportunity to safeguard against, in the most serious cases, domestic homicide. Domestic homicide can be a consequence of honour-based abuse, which is particularly grounded in lived experience in my constituency in Leeds. Honour-based abuse is widely misunderstood, meaning that hundreds of victims are not being helped and perpetrators are escaping justice. I'd like to thank my honourable friend, the member for Stourbridge, for highlighting it in her speech and the work she did when she was in the NHS. Honour-based abuse is a form of domestic abuse which is motivated by the abuser's perception that a person has brought or may bring dishonour or shame to themselves, their family or the community. It can take many forms, can be complex to identify, but perpetrators of honour-based abuse often use methods of coercive control to force their victims to behave in certain ways or subscribe to certain beliefs. For some people, the concept of honour is prized above the safety and well-being of individuals, and to compromise a family's honour is to bring dishonour and shame. This can be used to justify many types of abuse and even disownment or physical harm. Honour-based abuse is frequently missed or misidentified within health settings, often framed as family conflict, particularly when involving multiple perpetrators, rather than recognise domestic abuse and a form of violence against women and girls. This is particularly concerning as victims of honour-based abuse often have repeated contact with the NHS, including GPs, A&E and hospital services, sometimes over many years. These touch points present critical opportunities for early identification and intervention. This is tragically illustrated with my constituent, Fawzia Javid, a victim of domestic homicide who had multiple and ongoing contact with GPs and hospital services prior to her death. Fawzia's case highlights how risk can be present and escalating, yet not fully recognised or responded to within health settings, particularly where honour-based dynamics are not understood. Fawzia had such a beautiful and vibrant character. She could fill a room with joy just by her presence. She was full of life and soul. Helping others was so central to being that she was well known in the charity sector within Yorkshire. In December 2020, Fawzia married Kashif Anwar, but the marriage quickly became a prison of abuse. Despite reporting her husband's abuse to police on 2 separate occasions prior to her murder, Fawzia was failed on multiple levels. The abuse escalated, ultimately to abuser pushing her off the cliff at Arthur's Seat on a trip to Edinburgh. She died on the scene in the presence of female allies, who would later confirm Fawzia's dying words that pointed to Kashif as her murderer. When Fawzia died, she was 17 weeks pregnant with her baby boy. She had contact with the NHS during her pregnancy. Her family feel there were missed opportunities to protect Fawzia during this time. A risk assessment was started by one member of staff and completed by another, meaning there may have been vital missing piece of information. Handing it over partway undermined the seriousness of the process and of Fawzia's case. Fawzia's mother told me, "This was a clear example of how systemic failures, lack of accountability and poor safeguarding practices can leave vulnerable women at risk. Exactly why mandatory trauma-informed domestic abuse screening and better training for NHS staff are so urgently needed. It is vital that healthcare professionals support and encourage to identify signs of domestic abuse early. Routine, sensitive questioning could help protect people and potentially save lives." When Fawzia was pushed off Arthur's seat, at no point did her abuser dial 999. Instead, his first reaction was to call his father, showing how the family's complicity helped enable the abuse. The failure to recognise the dynamics of honour-based abuse and the involvement of multiple perpetrators played a significant part in the tragic loss of her life. If her case had been recognised for the multi-layered abuse it was and the honour dynamics involved, Fawzia might have had a chance to escape this violence. Domestic homicide reviews consistently identify health as a key agency, with recurring recommendations around improved identification of abuse, better information sharing, professional curiosity and escalation pathways, especially in cases involving honour-based abuse and coercive control. I'd like to thank Carmen Ivana, based in my constituency, for their essential work on this and tackling misconceptions, and thank Fawzia's family for sharing the story with me over many years, ensuring we will strive for this not to be repeated and never forgotten. Her story is a tragic reminder of why we must do more to recognise and address honour-based abuse and the impact it has on victims. Recognition, training and support in the NHS for victims of honour-based abuse is vital, and I look forward to hearing the steps the Minister takes to improve this. Thank you.
Thank you. We now move to the wind-up speeches from each of the spokesmen from the different parties. I say this for the benefit of our very large number of visitors. Liberal Democrat spokesman Helen Maguire.
Thank you, and it's an absolute privilege to serve under your chairship, Sir John, and I thank my honourable friend First Stroud for securing this vital debate. In November 2025, Surrey Police recorded 45 incidents of domestic abuse in my constituency of Epsom and Ewell, an average of 1.5 incidents every single day. But let us be clear, these are not just statistics. These numbers represent real people, mothers, daughters, sisters and children experiencing some of the most harrowing abuses imaginable. I've met with local organisations such as North Surrey Domestic Abuse Service, Guildford Rape and Sexual Abuse Support Centre and East Surrey Domestic Abuse Service to understand the support available to survivors. What I've learned is deeply troubling. The overwhelming number of women whose lives have been shattered by domestic abuse is staggering. Many victims face financial hardship, debt and isolation. Children grow up in fear, forced to endure violence in silence, their innocence stolen. Yet for some, escape never comes. Gemma Devonish, a much-loved teacher at a local all-girls school in Epsom, was found with 54 stab wounds in her home in December 2024. Her boyfriend was due to stand trial for her murder, but justice remains delayed as the trial is yet to begin. Aleni Godinho, a mother of 4, was stabbed to death by her estranged husband in front of her 3-year-old daughter while picking up her children from school in Ewell. Despite emergency accommodation being arranged for Aleni in Streatham, her children remained at school in Surrey. An examination of her husband's computer revealed he had tracked her phone, access to emails, and knew her new secret address. These tragedies are not isolated incidents, they are symptoms of a systemic failure. Yet recorded incidents are only the tip of the iceberg, because less than 24% of domestic abuse crimes are reported to the police. The NHS, however, has more contact with victims and perpetrators than any other agency. So this places healthcare professionals on the front line of the domestic abuse epidemic, not just in identifying and supporting victims, but in monitoring potential abusers. Consider the case of Emma Patterson, the beloved head teacher at Epsom College, and her 7-year-old daughter, Letty. Both were shot and murdered by Emma's husband and Letty's father, George Patterson. George legally owned a shotgun and held a valid licence. Before his last licence renewal, which requires a letter from a GP, he used an online consultation service to obtain antidepressants. Despite the online doctor having access to his medical records, they were unaware that he held a gun licence. and this medication was never declared to his GP. If medical professionals are on a line of defence against abuse, it's unacceptable that they're left in the dark about who owns a firearm. Mandatory medical markers would ensure that any health professional with access to a patient's records could see if they hold a gun licence. If necessary, they could immediately notify the police. This measure is overwhelmingly supported, and a survey by the Association of Police and Crime Commissioners found that 70% of existing certificate holders in England and Wales believe that a marker should be placed on medical records of gun holders. And among the wider public, support rises to 86%. So will the Minister commit to exploring the benefits of mandatory medical markers with colleagues in the Home Office? The previous government's guidance for health professionals states that domestic violence and abuse is so prevalent in our society that NHS staff will be in contact with adult and children's victims across the full range of health services. Yet too often staff feel ill-equipped to support victims and training opportunities vary widely across the country. Standing Together Against Domestic Abuse, STARDA, reviewed all domestic homicide and abuse-related deaths published in 2024, and they found that 89% had at least one recommendation for health professionals or the health system. STARDA's analysis also revealed that delivering training for healthcare workers at scale could cost as little as £2.66 million per year. So will the Minister review STARDA's recommendations and consider including them in the long-delayed workforce plan? I welcome the Government's announcement of the Steps to Safety initiative, which aims to better equip GP surgeries to identify and respond to domestic abuse and sexual violence. However, any initiative must be grounded in lived experience. The IRIS programme, a specialist domestic abuse training support and referral programme for general practices, has shown remarkable success. And practices with IRIS are 30 times more likely to recognise and refer domestic abuse victims to specialist support than those without. So will the Minister review the IRIS programme to ensure that Steps to Safety mirrors its success? Finally, it's clear that we are missing a critical opportunity to use the NHS to detect and help victims of abuse earlier. So will the Minister set out a national plan to ensure NHS staff across the country are sufficiently trained to spot the signs of domestic abuse? For Emma, Letty, Gemma, Alani and all other victims of domestic abuse, it is time to tackle this national crisis once and for all.
Official Opposition Spokesman, Shadow Minister Greg Stafford.
It's a pleasure to serve under your chairmanship, Sir John, and I congratulate the Honourable Member for Stroud on securing this important debate and his characteristically well-informed speech, and impassioned indeed, and his knowledge as a GP brings a real benefit to this chamber. Also want to congratulate the Honourable Member for Lowestoft on her appointment as the Government's advisor on violence against women and girls and her excellent and impassioned speech, and I'm sure the ideas that she has will be a great benefit to the Department and to the Government as a whole. This, Sir John, is a necessary debate, but it is also an uncomfortable one. The figures before us do not describe a system merely under strain. They describe a system that is failing, unfortunately, too many women and children. And if we're serious about change, we must be honest about responsibility and delivery. I want to thank the Honourable Member for Stourbridge for her experience and that she brought to the speech, and alongside the Honourable Member for Leeds Central and Headingley, their discussions on honour-based violence, which I think is very prescient for today. Also want to thank the Honourable Member for Bolton North East for her experiences, and I think we were all very interested to hear more about the IRIS system that she mentioned in her constituency. And as ever, the Honourable Member for Strangford bringing us a Northern Ireland perspective on this is welcome. And you, Sir John, despite the fact you haven't spoken in this debate, I think it is worth noting your campaign on Holly's Law, which is for a mandatory register of abuse against domestic animals, because so often abuse of animals is a precursor or is alongside abuse of humans. So thank you for the work that you do in that. And likewise, as honourable members have said, abuse happens across this country, and there is none of us who are untouched by it. In my Farnham and Borden constituency, I think of the horrendous case of Alan Jeremy, who stabbed his partner, Kirsty Wilson, to death, set her alight as their two small children were asleep upstairs. It's cases like that that I think bring it home to all of us. Now, the Minister will know that the NHS has more contact with victims and perpetrators of domestic abuse than any other public service, and that puts it in a unique position to intervene early, but it obviously also brings a responsibility to deliver. Now, the Department has set out ambitious plans around alcohol harm, neighbourhood health services and better access to support, and those ambitions are welcome, but ambition needs to be judged against the outcomes, and unfortunately nationally there is a growing gap between ministerial intent, which is welcome, and the frontline reality. The Office for National Statistics show that 6% of women aged 16 and over were victims of domestic abuse. And likewise, police last year recorded more than 1.35 million domestic abuse-related crimes and incidents. The consequences are often fatal. There were 108 domestic homicides that year, 83 of whom were women. For adult female homicide victims, 6 in 10 deaths were the result of domestic homicide, almost all at the hands of a male partner or ex-partner. Domestic abuse is also a significant driver of suicides, we've heard. Between 2020 and 2024, 98 suspected suicides followed domestic abuse, including children. This is not marginal, it's systemic. So the government's freedom from violence and abuse strategy is welcome, but its impact is undermined by persistent failures in delivery. Training remains inconsistent, referral pathways are unclear, staff lack time and the capacity to act. And the evidence is clear. As mentioned by the Honourable Member for Richmond Park, in June 2025, Standing Together Against Domestic Abuse reviewed domestic abuse-related deaths and found that 89% in 2024 contained at least one recommendation for healthcare professionals or the wider health system. Time and time again, as the Honourable Member for Stroud mentioned, opportunities for intervention within the NHS were missed. Yet, at precisely the moment when this learning must be embedded, the government is reorganising the NHS, abolishing NHS England and cutting integrated care board budgets. Standing Together has warned that these changes risk weakening domestic abuse and sexual violence protection work at local level, including in training, coordination and follow-through. A system that is restructured, distracted and under financial pressure cannot deliver the prevention that we all want. So in Surrey, police receive around 19 domestic abuse calls every day. Domestic abuse is now more prevalent than shoplifting. These are systemic failures playing out in real time in our communities. I want to briefly speak about a young woman who lived in my constituency, Skye Nichols, who was killed in 2023 at the age of just 22 after nearly 2 years of coercive control and abuse by her ex-partner. I've spoken with her family and friends who were campaigning for mandatory psychological assessments following a police report of domestic abuse. One told me that too often the focus remains on visible injuries, while psychological abuse is underestimated or dismissed, even though its effects often last far longer than physical harm. For families and friends, mental health support is frequently fragmented or absent, despite them often being the first to spot the warning signs. Prevention does not begin at the point of crisis, it begins with early, trauma-informed intervention. Now, NICE guidance clearly sets out how NHS staff should respond to domestic abuse, but guidance alone doesn't save lives. Women's Aid's 2025 report found that just over half of referrals into community-based domestic abuse services were rejected, nearly a quarter because services couldn't even contact the victim. When support is reduced to just phone lines and signposting, unfortunately women fall through the cracks. So detection is really important, and often accident and emergency is where the physical signs of this abuse is seen. But as the Honourable Member for Stroud mentioned, primary care is often the first point of contact, and we must use GPs and other primary care services expertise and give them the time to effectively identify, intervene and support those victims. But the NHS cannot act alone. Sir John. The justice system must also command public confidence. That is why the early release scheme for serious offenders, including rapists and murderers, is so damaging. It sends entirely the wrong signal to victims and undermines trust in the institutions meant to protect them. And we as the Conservatives will continue to oppose this policy. Under the previous Conservative government, we introduced a statutory definition of domestic abuse through the Domestic Abuse Act 2021, recognised children as victims in their own right and published violence against women and girls strategies and invested significantly in victim services, mental health and suicide prevention. But we are honest enough to say that legislation alone is not enough. The Domestic Abuse Commissioner has shown that only 6% of police-recorded domestic abuse cases result in a conviction, and only 1 in 5 victims feels confident reporting abuse. That demands competence and delivery, not the constant structural upheaval that we're going to see both in the justice and in the health systems. We made good strides in this area, and I do genuinely believe the ministers in the department currently are doing their level best to move forward. However, I think we all agree there is so much to do, and where the government is making those strides, we, as the Conservatives, will support them full-throatedly. So I close with 3 questions to the Minister. First, the government has I welcome the government's announcement of a 5% funding uplift. But given rising costs and national insurance increases, how much of this is a real terms increase and how much will go directly to the front-line services for victims? Secondly, when will mandatory safeguarding and domestic abuse training for all NHS staff formally begin? What will rollout look like? And when will the entire workforce have completed it? And finally, what assessment has the department made of the case for mandatory psychological assessments following a police report of domestic abuse to ensure victims receive early trauma-informed support? Sir John, you do not prevent violence against women by just abolishing institutions, cutting local capacity and releasing dangerous men early. You prevent it by enforcing the law, backing the front line and putting victims, not the systems, first.
Thank you. Minister of State for Health, Secondary Care, Karen Smith.
Thank you, John, and it's a pleasure to serve under your chairship this morning. I've headed myself. And I really want to thank my honourable friend, the member for Stroud, for bringing this debate forward. And as others have said, bringing his actual direct experience as a practitioner and as still a jobbing GP amongst his other roles, I think was really apparent through his speech here this morning and his expertise in this debate. This is something that I've long been talked about as my role as a Member of Parliament, an absolutely massive issue here for me personally and for me as a constituency MP. I think all colleagues will be aware of how widespread domestic abuse is through our casework. It is one of the biggest issues for me in Bristol South, and it should keep us up all night to think about the number of women who fear injury or worse at the hands of their partners. The ONS, the Office for National Statistics, estimates that well over 2 million women have experienced domestic abuse in England and Wales in the last year alone. And year on year, we know that domestic homicides are present in all our constituencies. There are now 108 domestic homicides in the year ending March 2024. So getting the right support early could help prevent these needless and tragic deaths. On my honourable friend from Stroud's particular points, on his ask to publish a comprehensive plan for health, I would say that we now have a clear agenda for officials as set out in the commitments in the Violence Against Women and Girls strategy, and I will personally ensure that we are making progress on that through 2026. He asks to increase the department's contribution to the VOG strategy in future budgets, and I'm happy to confirm we are doing that over this spending review. As well as the £5 million annual investment for victim and survivor support services, we are committing up to £50 million over the next 3 years to the rollout of Child House. In addition, the department will also provide dedicated funding for Steps to Safety, a referral service, as we've heard, for those affected by domestic abuse, and I will come on to both of those points in my speech. He's also right to emphasise the importance of specialised NHS training on domestic abuse, and I will also pick that up in my comments. So, John, tackling domestic abuse has to become everyone's business, as we've heard here today. So the whole of government is behind this agenda to prevent abuse and save lives. And I think we saw, certainly before Christmas, if people didn't recognise before, the personal commitment of the Prime Minister to this agenda. I spoke plainly from a possession bench myself about the cost of living crisis and how that was impacting women. And I won't sugarcoat that fact from my position now in government. Many women face the impossible choice of staying in an abusive situation or destitution. And my right honourable friend, the Work and Pension Secretary, is doing everything he can to support people back to work more generally, particularly to help women gain financial independence and keep them free of coercion. And while all of this is necessary, it's not sufficient, because NHS staff will also play a vital role in helping victims and survivors to access health, housing and justice. Healthcare, as we've heard today, are often the first point of contact
offering support, treatment and rehabilitation. They do have their eyes on those at risks. And my honourable friend from Stroud made an excellent point about fragmented services. And to take the point from the opposition spokesperson, with that recognition does come responsibility for delivery, and we absolutely recognise that. The support that we offer must be consistent, responsive and easier to reach. And as the Liberal Democratic opposition spokesperson said, these are not isolated instances that we have heard from many colleagues this morning about their constituents, but it is a systemic issue. And as my friend, the member for Bolton North East, said in her excellent remarks, we need to join the dots. Like all our public services, teachers, social workers and the police, the NHS already does play an essential role in safeguarding. And as my friend from Leeds Central and Headingley said, that includes dealing with so-called honour-based killings. For instance, partners are often asked to leave the room before a midwife asks the mother whether she feels confident no one will try to hurt her or a baby. We take our duty of care towards survivors of abuse extremely seriously because violence against women and girls is, as we have heard, a public health emergency. GP surgery staff are at the front line of our commitment to safeguard lives. Since we came into office, we have supported primary cares and GPs as the front door to the NHS, with recruiting over 2,500 more GPs. We have seen some patient satisfaction improving with that, recognising the access is improving, and having online consultations, ending that morning scramble for appointments, supporting that front line. And this year, we will work with all ICBs to help staff in GP surgeries to identify, support and refer victims and survivors of domestic abuse into wider support services, as we've heard, these steps to safety strategy. And it will introduce, firstly, training for all staff in GP surgeries to help them spot the telltale signs of abuse and give them the skills and confidence to offer support to affected people. And second, a specialist worker who will advise GP practices on supporting victims and survivors to take their first steps to safety through linking them with local support services. And third, we will learn from the excellent practice that is already happening locally, for example, in places like Devon, Cornwall, Birmingham and Solihull. These services could help women to escape their abusers and get back on their feet, whether it's to find housing, get back into work or put the perpetrators behind bars. We're rolling out this initiative from April, starting with 10 ICBs in the first year, and by 2029 any victim or survivor in England will be able to get the help they need by talking to staff at their general practice. So, John, we are determined to ensure these services don't become a postcode lottery, and it is a shameful truth that some of the most alarming health inequalities are those faced by victims and survivors of domestic abuse and sexual violence. And that is why my Right Honourable friend, the Secretary of State, has asked my Honourable friend, the Member for Lowestoft, to advise the Government, and again she made an excellent contribution to this debate this morning. So she will be looking at how we reduce the impact of alcohol on violence against women and girls, how we commission services to ensure the right support is in the right place, and how we embed support into neighbourhood health services so women and girls can be connected to the specialist support that they need. A lot of colleagues talked about training. I think the member for Richmond Park and for Stourbridge also talked about training. So if I can just assure colleagues that I think we do need to remember that health professionals are trained to identify and respond to all types of violence and abuse using blended learning methods, including e-learning, in-person training and supervision. National mandatory safeguarded training is being strengthened for launch in late 2026. We do recognise that that needs to be done. This will reinforce to staff their safeguarding responsibilities and support them in identifying and responding to victims of abuse. It will include the importance of recognising the impact of trauma and cultural barriers to discussing abuse. And in terms of ensuring it happens, it is the responsibility of employers to ensure staff complete that mandatory safeguarding training. And the Care Quality Commission do assess compliance with this requirement. NHS England Safeguarding oversees this and has audited integrated care boards on completion rates, so we will strengthen that. In terms of child sexual abuse, it does take immense bravery for survivors, not least survivors of child sexual abuse, to come forward and tell their stories. And we are doing everything to end the trauma of children and young people having to relive their ordeal over and over by bringing a range of specialist support services under one roof to every NHS region in England. This is called the Child House model. We've started to recruit those extra mental health workers by the end of this Parliament to help survivors who still carry the scars of their abuse. We're more than halfway towards this target, and whenever and wherever a victim or survivor contacts the NHS, it must be there for them with compassion, care and dignity. Just to pick up on some of the comments made by the opposition spokesperson on this issue, the changes we're making to NHS England are to resolve many of the problems that he's outlined. We have huge problems with pathways, a result of layer upon layer of provision and bureaucracy in the system over the last decade. Confusing pathways, confusing levels of accountability, massively increased cost with no improvement to services received at the front line. We need to give support to local delivery and where people present, and that is our intent with these changes. I wasn't aware that the opposition were against the abolition of NHS England, but we obviously will make sure that we focus on service delivery as we go through the changes, because our starting point is that women and girls who are victims of abuse are never responsible for the abuse. The perpetrators are responsible, but tackling it is everyone's problem. That's why my right honourable friend, the Home Secretary, has started to deploy domestic abuse experts in 999 control rooms, building on best practice across the country, including some in my own area of Avon and Somerset. It's why my right honourable friend, the Justice Secretary, has introduced new measures to protect victims of stalking. It's why my right honourable friend, the Education Secretary, is taking steps to challenge misogyny in the classroom. And in response to the member for Strangford here to highlight the really shocking levels of killings in Northern Ireland as well as abuse. And it is good to have that voice in this place, because I think sometimes, as he knows, I take a great interest in Northern Ireland, but we don't often hear about that, the particular situation there. I can assure him that the Home Office, as the lead department, has been working with all devolved partners in terms of producing the strategy. The Department of Health itself is also sharing learning, but that's absolutely something we need to keep an eye on, that we support colleagues in Northern Ireland on this agenda. Working across government, it is why I'm determined the NHS will do its part to halve violence against women and girls by the end of the decade. Our strategy is not a government plan, it is a national endeavour. And everyone in this room, or people watching on screen, has their part to play. So I do want to end my remarks by speaking directly to the survivors and anyone who may be trapped in an abusive relationship. This government is on your side, and I think we've heard this morning willingness across all parties to make this work. We've not forgotten you. You can get in touch with the Refuge National Domestic Abuse Helpline, Women's Aid, Respect, an organisation that works with male victims and perpetrators of abuse as well. Please get in touch with these or other specialist charities, or contact your local sexual assault referral centres. This government is determined to make this strategy work, and I'm really grateful to have the opportunity to respond to this debate this morning.
Thank you, Minister. Dr. Simon offer to say a few concluding remarks. Simon.
Yes, thank you. And can I thank the Minister and all the people that have spoken, all bringing fantastic experience of this really difficult problem. And can I just say two very simple things? What we need to do is we need to imprint on healthcare workers, think domestic abuse, so that we don't miss it. So if someone presents, we must have in the back of our minds, is this domestic abuse? And in that way, that will help identify victims much earlier. And after that, we need to enable them to refer on a simple and effective process which will bring support to those people immediately. So can I thank everyone here, and to you, Sir John, for chairing the meeting. Thank you.
Thank you. Thank you for winding up. This has been a really important debate, and I'm so pleased that everyone was able to contribute. How I would have spoken in this debate had I not chaired it, and I hope I would have spoken with the same kind of passion and insight that everyone has shown. Thank you. Order, order.